Well, welcome back. It is the Just Start the Conversation podcast, and it is brought to you by St. Luke's University Health Network. You can find this podcast at sluhn.org, YouTube, Google, Spotify, all those fun spots you get your podcasts. You can find this one there. We sure do appreciate you tuning in. My name is Kevin Crockett, back once again with, well, one of my partners in crime, Amie Alanson Dundon is here. Jody McCloud Missmer, what's happening with her today? Does she have an excused absence? What is this?
Her absences are never excused. She's off gallivanting somewhere probably fun. I don't know.
Classic gallivanter, that one. Anything to get out of work.
Yeah.
So we have some wonderful shoes filling her role today. With us is Dr. James, who is the chair of the Department of Psychiatry and Behavioral Health over there at St. Luke's. Dr. James, we've already discussed that you've done some interviews and things of that nature before. We also discussed cartwheels. Are we expecting that in the beginning of the podcast, middle, back end? What are we thinking there?
They'll definitely come in later. I want people to stay on tune with us for a bit, and then if they stay long enough, they'll get rewarded.
That's a man after my heart. Make sure people stay tuned in as long as they can. We call that a tease in the radio business. Well, listen, you two have a wonderful relationship already. I've already seen it even before we started rolling today. So I'm going to let Amie kind of set us up and take this one over from here. Give Dr. James a little bit of an introduction and just kind of where our conversation is going to be going a little bit today. So Amie, after you, my friend.
Thanks, Crockett, for that fantastic introduction. Thanks for being here, Dr. James.
Very excited. Thank you, Amie, for the invite.
Absolutely. We're excited to have you today because of your wealth of expertise and knowledge in the field of psychiatry, for all that you do for St. Luke's, but really talking about a psychiatric disorder, depression, major depression, that is super, super common. We know that depression is the leading cause of disability in the United States for those aged 15 to 44. We see it in our work at St. Luke's every day. Mm. And, I think one of the things we want to pick your brain about is what are we doing in terms of maybe some alternative types of treatments, some new types of treatments for depression, specifically for folks that have been dealing with depression that maybe they've been unable to find success with traditional medications, that sort of thing, to talk a little bit about the evolution of psychiatric treatment for depression.
Mm-hmm. Absolutely. Look forward to that.
Okay. So what would you, I guess one of my questions for you is, what's your thought on how we're doing treating depression?
Could always do better, let's say. I'll keep it a simpler response.
I mean, we've been treating depression for hundreds of years.
Absolutely. And we've come a long way, but still our treatment is in its infancy. We have so much more to learn and do. So when you look at the people that have depression, I looked at a 2021 study that showed about 7% of the U.S. population any given year has an episode of depression. And about half of those people will actually seek medication management, which is about 9 million people every year. Unfortunately, a third of those, about 3 million people, will have what's called treatment-resistant depression. And we define that differently by different standards, different clinical standards, different research standards. So there's not a universal definition, but one that I think is useful is persons that have had 2 failed antidepressant trials. And that means there's been a fair course. Unfortunately, medications that we use take a long time to work. So it can take several weeks, even up to maybe 3 months to have an effective response. And you have to have the right dose. But if you have those 2 factors at play and they still don't respond to 2 medications, that's considered treatment resistant. So you're talking about how far we've come. We certainly have. But really, there is a good subset of people that have either chronic depression or treatment resistant depression.
Dr. James, I have a question. The idea of depression, maybe some of the misconceptions that people have, because when you say things like 2 failed depression trials and things of that nature, and that medications maybe haven't worked so far, I think there's probably a misconception about what depression is. For most people, it's probably like, oh, you're feeling a certain kind of way, here's a medication for that, and that's what it is. The words evolution of treatment were some of the first words that we used kind of introducing this topic today. Can you maybe just go into a little bit of what you feel are those misconceptions to the everyday person that maybe probably doesn't quite understand all that it entails? And with that, I'm sure that person's next question would be like, okay, well, if it isn't medication, if it isn't how I feel like I've always understood it, what are some of the ways that treatment has evolved that can kind of give people more positive scope on where depression is and where it's going and how it's being treated?
Yeah, excellent points and questions. So first off, major depressive disorder is defined by a depressive episode that lasts at least 2 weeks and has significant symptoms associated with it, along with a significant functional deficit for an individual, an impairment of quality of life, a perceived significant impact on their ability to do their day-to-days. So it can come in ways of sleep disturbances, either increased or decreased sleep, altered appetite, increased or decreased, altered pleasure or joy in things that used to bring one joy, a sense of depression, energy changes. There's lots of different factors that can go into play. Even, unfortunately, people can start having some darker thoughts, wishing life was over, or not waking up, or perhaps actual suicidal thoughts or intentions.
Even psychotic features.
Absolutely. In the most severe senses of depression, it can come with hallucinations, both visual and auditory are the most common ones. A sense of guilt that's profound and actually not really tied to anything. Typically, it's irrational guilt that comes with depression. And so many other symptoms as well can be considered. But the bottom line is all of these things don't have to be present, but several of them do. And when people have these, and maybe they're laying on the couch and they don't have the energy to get up, and they're not getting to school, or they're not getting to work, or they're not taking care of their family and not taking care of themselves, then those are really clear problems or concerns. Now, I want to be also very direct that people feel sad. And we're not treating normal emotions. We're treating the exceptional emotions that are very extreme, very intolerable, and very damaging to one's life.
Yeah, we treat, so along with psychiatric medications, certainly psychotherapy we use to treat depression. And, looking at psychotherapy as maybe first line, before somebody goes down that path of medications, I think is important, because sadness, like Dr. James just said, is a human thing, and we all experience it. And sometimes you just need to talk about it to figure out where you fit on that spectrum, on that continuum. And then as we move along, and perhaps psychotherapy alone isn't working, then we look at medications, and then the docs will try as much as they can when it comes to medications and working with your treatment team. And then where I'm fascinated by the history of the treatment of depression over the years, and part of my, we talk about this all the time, Jody and I and Crockett, is Jody and I's fascination with true crime. And I'm listening to this is going to fit
James,
in, Crockett.
You have
I'm not,
no idea
listen.
how fascinated they are with
It's a deep rabbit hole, I hear, yes.
Right. So, but I'm listening to episodes right now in a podcast where they're talking about the lobotomy. And the beginnings of the lobotomy, the leucotomy, it was called at first, and I'm fascinated by it. But as I'm listening to discussions about the lobotomy and some unfortunate things that happened along the course of all of that, how far we've come with ECT and TMS, and I think people are a little afraid of. Yeah, modern medicine is amazing, but the history of some of the things we've done in psychiatry is a little bit, I don't know, is a little bit sketchy. Hundreds of years ago, we've come a long way, baby, right? So I think it's important to talk about that and say we don't have to be scared anymore.
Absolutely.
So Amie, if you don't mind me jumping in there, you threw a bunch of acronyms out there, so I want to give people a little bit more insight on that. You're very passionate about how far things have come along, particularly with, I believe you said ECT and TMS.
Right, so electroconvulsive therapy is ECT, and transcranial magnetic stimulation is TMS.
Oh, that was my guess, was transcranial.
That was right there on the tip of your tongue?
That was it.
I
That's
knew
what
it.
it was, yes.
Yeah.
So can we elaborate on that a little bit? Because, again, for the person that isn't studying this, isn't looking at this, you said, Dr. James, a couple of the words you used, the main one that I took away is feeling sad, kind of as the start of things for people. And I would imagine it probably for both of you is a real a real aggravating thing to hear somebody maybe just say, oh, they're being lazy, or stop being sad, and things of that nature. And I think part of the evolution of depression in general, as we talk about kind of the evolutions of treatments, is I think people are more aware now that, hey, it's not just necessarily somebody like, oh, I don't feel like getting out of bed because I'm lazy. It's I don't feel like getting out of bed because there's a lot more going on there. Can you just elaborate maybe a little bit more on some of these, the ECT, the TMS, the evolution of these treatments, as Amie pointed out, and also just like I said, I feel like those kinds of things have to really be bugaboos for people like you and Amie, where somebody just says, hey, I think they're being lazy, where you want to step in and say, no, we're gonna dive into this and figure out what's really going on.
Sure. I want to speak to that first, and we'll talk more on TMS and ECT. But yeah, I mean, imagine yourself having a physical condition. Let's say that you're laid up being very ill, and then your significant other comes in and says, you're being lazy, get up, go do stuff. Or you're upset at something that very dramatically happened just now in your life, and somebody says, hey, calm down. I mean, these are not effective. They're very dismissive. They're not recognizing compassionately what another person is going through. And I think it's important for us to put ourselves in another's shoes and recognize there's a lot going on, even if we can't perceive it, even if you can't take a temperature of somebody. There's internal things, and you have to trust that that person is actually dealing with something very, very difficult. And I think that's the first step. Is making sure that we're compassionate, that we're recognizing somebody needs our help and support, and just being there and trying to understand where they're coming from. And on top of that, I also want to say, before we get to treatment-resistant depression, Amie brought up a good point. Therapy is a huge first-line approach to getting treatment, but also, looking at your lifestyle. Are you sleeping right? Are you eating right? Are you exercising? Are you avoiding substances? Alcohol makes us feel good in the moment, but it actually is a depressant. So there are things that we should really do in either moderation or completely abstain from in our lives to make sure that we don't go down those paths. And not all those things are things that we can control. Certainly some people have trauma history. Some people have situational factors in their life, people in their life, work situations, financial situations, things that they might have control over that can certainly weigh on and push us into that depressive state. Therapy can be a great way to identify those and work on those, but not always can we come through. And so then when we do the medications, like I said, maybe about a third of people that take medications don't actually get the response that we want. And then we look at other options. So we've tried multiple medications. We've tried different classes. We've added medications together. We've made sure that there's no medical comorbidities like thyroid disorders or other problems going on. And we're really scratching our heads about what we can do next. So TMS, transcranial magnetic stimulation, and ECT, electroconvulsive therapy, as Amie said, are two of the best standards. There is also Spravato or esketamine, which we can talk about as well. ECT is the oldest, and that's unfortunately the one that has the baddest or worst, I should say, kind of perception in society. You look at One Flew Over the Cuckoo's Nest. That made it famous in a very bad way. And I think Amie brought up some good points. I think people had good intentions in the past about what they were trying to achieve. Psychiatrists weren't out there just to torture people and have a good time with things, but they were experimenting desperately to find relief for individuals. And they did it in probably not the most moral or ethical way by today's standards.
And certainly. It was psychiatrists and neurologists, like neurology, so the disease of the brain is studied by many famous, brilliant people throughout the years.
Absolutely. And so really it was desperate efforts to try to help people. And what they did find through ECT is a dramatic improvement in depression. Now, we've come a long way in how we present ECT. Now we use anesthesia. People are sedated. They don't even remember the episode. The electric, I guess we'll talk a little bit more about the details of ECT in a moment. But certainly ECT and TMS are both very effective. When you look at number needed to treat, for example, and let me just break down that definition. A number needed to treat is assuming somebody gets no treatment versus a treatment. How many people do you need to treat to have success? So if you have a number needed to treat of 10, that means I have to do this treatment 10 times to have one success. And when you look at TMS, it's about a 3.5 or so, which means you have to treat 3 or 4 people to have one person succeed in resolving their depression. Compared to TMS, ECT stacks up a bit better. About 80% of people that go through ECT have their depression resolve. And when you put them head to head, the number needed to treat for ECT is 6, meaning if I treat 6 people with TMS, one of those people would have done better with ECT.
I didn't know that.
Man, you want to talk about an evolution of treatment? That's certainly some interesting statistics there. I'm curious, as we've kind of talk about what could lead to a depressive state or a depressive episode. You mentioned a tragic event that could happen in somebody's life. One thing that I certainly, I have 2 young kids, 7 and 3. And as you're hanging out with other couples and you're learning about other families, you're kind of hearing about different situations. And certainly one that I know has come up quite a bit in the circles of people I know has been postpartum depression. And can we kind of talk about when I guess with a tragic event, you can kind of maybe from the outside looking in say, oh my gosh, this person just had an unfortunate passing in their life, unexpected, that might happen. With somebody like myself, who is obviously never going to deliver a child, wouldn't understand the neurological things that could happen to lead to postpartum depression. So I guess my question for you two would kind of be, it's very obvious to look at a tragic event and say that this is a cause of why a person is unhappy. For these things that are neurological, a thing like postpartum depression, things of that nature, how is the approach maybe a little bit different? Because it feels like maybe on this side you have something that feels not that postpartum isn't an obvious thing, but with a tragic event, you can see a person and say, this is very obvious. With postpartum, it is a kind of a sudden shift in the same way a tragic event happens, but it's for a happy event. But I know the question that I'm trying to ask, and I'm kind of going in a roundabout way of asking it. But basically, the difference between a tragic event and something that's actually neurological, how do you kind of begin to decide where the two are different and where the two intertwine?
Well, I think, first of all, we need to remember that human beings are all different, right? So you may go through a trauma and Dr. James may go through a trauma, and you both may have very different reactions to that. One of you may end up developing an acute stress reaction, one may develop post-traumatic stress, or one may really be able to kind of work through it in a couple weeks and be fine. So a lot of this is, just because somebody goes through an obvious physical trauma, like a war veteran, right, doesn't mean they're going to come back and have a diagnosable psychiatric condition. So some of it is talk therapy and working through it to see exactly what's going on. Sure, if somebody experiences a trauma, we want to do the very best we can to work with them within the first 48, 72 hours after that traumatic event, so that we can kind of go through doing some critical incident stress management and helping to kind of relieve symptoms so that they don't lead to some sort of awful post-traumatic stress disorder down the road. So the sooner we can get to somebody after a trauma, the better. Now, postpartum depression can start during pregnancy. It doesn't even have to wait till after pregnancy. An OBGYN would be somebody's probably first line or PCP to kind of talk about those feelings, because they're seeing those doctors pretty regularly. And those docs hopefully can kind of pick up on when it's normal, quote unquote, and when it's problematic. Right. Absolutely.
And certainly you brought up a great point with the hormonal fluctuations. Really, it's a roller coaster that comes with pregnancy. And of course, at delivery, there's a dramatic shift in hormones levels. And there are treatments out there. Zulresso is an infusion. There's actually a brand new one that was FDA approved orally for the same type of medication, Zurzuvae, and that is actually getting to the market soon. That I think can really address those people with postpartum depression. But you bring up the greater point, which is how do you identify, and Amie was speaking that too, who's going to experience it, who's not. Family history certainly is important. There's genetic components, there's biological events, there's environmental events, there's chemicals that we put in our body knowingly or unknowingly that can impact us. And all of these things play factors that we really have a hard time pinpointing. Like, we don't have that crystal ball. We're still working on designing it. I'm on my 100th.
Come on, where's this?
I know. I'm on my 100th iteration, and each one fails, but I will get there. I will find a better way. Speaking to that, there is pharmacogenetics, what I think is important. You might have heard of personalized medicine is another way. So personalized medicine is basically understanding one's biology and what would be the right fit. And we're not just looking at mental health. We're looking at all aspects of medical care. But it's in its infancy. Right now we use it. Basically, it tells us maybe you'll have a reaction to this medication, or maybe your genetics suggest that you're not going to be as responsive to this class, but that's about as far as it goes for mental health right now. So really we don't use the pharmacogenetics very often unless somebody's trialed medications or failed them or had lots of side effects. It might be useful in helping us kind of stop playing, throwing the dart at the dartboard, if you will, as many times, but still it's not going to tell us what's going to work. And so we really don't have a great answer to your question. Now I'm going roundabout in the same way that you did to tell you that it is just too challenging to identify every time what's causing what.
Sure. I think as we keep coming back to this phrase, evolution of treatment, I do think as much as it is hard to hear somebody say, just stop feeling sad, stop being lazy, those sorts of things, I do think that some of the stigma around mental health and depression has come a long way, certainly as we're talking about an evolution. The community that is mental health, people like yourselves, not only that, but people who are battling depression themselves, having a community with other people who are perhaps battling depression themselves, the people who are caregivers, family members, close relatives, just that community of mental health. As we talk about an evolution, I feel like that has to be such a bright light for both of you as the stigma around depression has kind of gone away. Amie, I'll start with you. Just kind of that where you've seen that evolution in your time dealing with patients dealing with depression and families dealing with loved ones dealing with depression, and just that community in general, the perhaps bigger community than ever that says, I've been dealing with this, I still deal with it, we're going to kind of get through this thing together. Can you maybe just start with that, just kind of as we talk about evolution, the evolution of just kind of the positive looks and positive perspectives of the community in mental health?
Yeah, you asking me that question makes me realize how old I am and how long I've been in this field. I'm thinking back to, 30 years ago, 25, 30 years ago. And the fact that
you were 8.
I was 8. Yes. and when I was 8, the fact that we just didn't, it was never talked about in school, right? Ever. And I think about the evolution in the school system of mental health and decreasing the stigma, to the fact where, at least on the eastern seaboard of the United States, school districts have really embraced fighting stigma and having mental health professionals embedded in their school system, and have, very proudly have posters and buttons and all sorts of cool stuff, and clubs and therapists in the schools. And it's really become a very accepted, applauded form of mental health, just awareness. It's okay. Teachers are open about therapy, and everybody seems to be it's just viewed in a much brighter light than it used to be in schools. That being said, then those kiddos that we're raising in that healthy, non-stigmatized platform are going to grow up to be adults who are carrying that forward, and also then having it be a really having us have adults who are adjusted very well to speaking about and openly talking about their sadness or anxiety or mental health. So I think it's been massive in schools, the forward progress for sure. And I also have seen it in the world of physicians, and in the world of lawyers, doctors, just people just being a whole lot more open about physical health is as important as mental health, and openly supporting each other, walking the walk of depression, anxiety, stress management, burnout. It's talked about much more widely. Yes, there's still stigma. Yes, there are still people that are like, oh no, you would never catch catch me going to a therapist or a psychiatrist. But for the most part, it's become, dare I say, almost like the thing to do. Like, it's cool to have a therapist now, which, gosh, we've come a long way.
Start printing the t-shirts now, St. Luke's. Start
Right.
printing the t-shirts, yeah. So Dr. James, I'm going to ask you to kind of piggyback off of that. Just the community of mental health and how you've seen it kind of change over time. And I guess we can second part that question as we've talked about the evolution. Where would we like to see things go? We've talked about some of the different actual physical treatments. I'm sure there's plenty more on the horizon. I'm sure there's more and more studies that are being done that give you both a lot of positive vibes about where the battle against mental health is going. But just that community, that mental health community, how have you seen it grow? And from here, where would you like to see it go? What are some great next steps that people can take and studies can show that would really, for yourself and Amie, give like a really big kind of a boost of this is really pushing in the right direction?
Yeah. Amie mentioned several great points. I think also you look at the Iron Pigs, there's lots of companies and groups out there that are really messaging well. They have special nights for like suicide awareness and other kind of programs to support destigmatizing. Two of the challenges I think is, I mentioned guilt earlier as one of the symptoms. And you can just have one person, and there's generational awareness, as Amie said. So newer generations are going to be better about being aware, being less stigmatizing towards depression and whatnot. There will always be some degree, but I think when you're looking at people around one who is having depression, it just takes one person around that person that has depression to make them feel really bad about it, or to make them feel really guilty, or to stigmatize. And so, as much as we've come a long way, I think that even a small percentage of people can really muck it up for a lot of the people that are still struggling, to make them feel bad about seeking help, or wanting to be shy about saying they need help, or wanting to talk about their emotions. So the other piece I'd like to say is, I think, and this is a hard one, is how do we help people who are trying to be employed, who are trying to be functional, who have these mental illnesses or these challenges that require them to take time away. There's still some disparity, I think, in how mental health conditions are treated on a societal level when we look at policies, when we look at disability opportunities. And it's not to say those people can't get those services, but I think that also makes people feel like they can't speak out. They can't say something. They're afraid they're going to lose their job, or they're not going to be looked at the same way, because mental illness can really be disabling on an employment level as well, and people might have a perception that I can't say something because it's going to look badly, or my employer does in fact say something about my mental health in a non-compassionate way, and because it's interfering with my performance. And so I think not only on a personal level, I think we need to do on a larger level in that way too, to get better.
Yeah, and I hope it doesn't take another 30 for us to get there. Like, I just said, like, the last 25 or 30 years, we've come a long way, but we can't let it take another 30 years to get us where we need to be. We don't have that luxury as a society, I think.
No, and resources out there, the funding, there's lots of opportunities. What do I envision? I mean, we're never going to be walking around with the daisy chains in their hair and frolicking through the streets. Life isn't going to be always magical.
You never know. I would wear a daisy chain in my hair.
I just got these daisy chains. Now I got to take them to Amazon.
Crockett,
take this back.
you got to send them back.
Hey, no, embrace those if you have them. But I think the reality is we're always going to have strife. We're always going to have depression, sadly, in our world. There's factors that are going to be in everybody's life. But how can we make things better? I think starting young with making sure people are aware, they're well informed, they understand coping skills, they understand resources, they understand how to support each other and be compassionate. Having healthy dialogues, I think communication goes a long way when we know how to talk effectively to people. And like, I'll use the generic I statements, right? I say this, I feel that, rather than you did that or you made me feel this way. Owning our emotions, but also communicating in a way that makes people feel heard and supported, I think is going to help a long way. And so by bringing attention not just to mental illness. I want to bring attention to mental wellness. I want to make sure that we find a way to focus on the offensive rather than defensive when it comes to our mental well-beings, and allowing people to engage on a very early level and in a family level to partner with those around one. Because like I said at the beginning of this part of the conversation, if you just have one or two bad people or bad influences in your life, that can really taint it for everybody in that family or that setting, and make it a lot harder to overcome.
I think that was very well said. Amie can attest to this. I've talked multiple times about my therapy experiences throughout my life, and it's fascinating that the key word I feel like I took away from you just now, Dr. James, was communication, and how my job is to talk on a radio, and man, did I need help with my communication skills, as I found in therapy. So I do think that is such an important thing, and just I feel like a really good place to start as we're talking about ECTs and TMS, and we're talking about all these tests, and if they're necessary and needed, they are wonderful things to utilize. I think for a lot of people, and especially as there are people who still have that negative stigma around mental health and around depression, that first conversation, those first opportunities to go to therapy and talk, and to your point, say, not so much you're you, but I, and kind of how can I look at my place in this situation, and how can I focus on myself, and as a result be better to the others around me, I think is just such an important part. And yes, it does feel like the discussions around mental health have certainly come a long way, even in a short period of time, even since Amie was 8. It's incredible how far they've come. Wow. So Dr. James, listen, we would love to have you anytime. I think this was a really amazing conversation, a wonderful conversation. Again, I think Amie can attest to the fact that we start the conversation. We start conversations, and then all of a sudden, as we're going through our notes, we're going, ooh, we could have a whole other episode on this, that, this, and the other. I'm sure we would love to have you back on once again down the road. Maybe Jody can stop skipping class and be a part of those conversations as well. No, I
think she's dodging me, but next time I'd be happy to have the opportunity to talk more, and whether or not Jody's here.
Jody should say she's focusing on her mental health, and we should allow that to happen.
Very true.
That's right.
I think we've all taken from this one today. But Dr. James, thank you so much. He is the chair of the Department of Psychiatry and Behavioral Health over there at St. Luke's. Amie, Alanson, Dundon, always a pleasure, my friend. This was an excellent conversation, as always. Thank you for holding down the fort on us on that end over there. And thank you for being great, as always. And happy 33rd birthday is what I did the math correctly.
Thank you, Crockett.
Thank
you for all you do.
You are absolutely welcome. It is the Just Start the Conversation podcast, and it is brought to you by St. Luke's University Health Network. For Dr. James, for Amie, Alanson, Dundon, I am Kevin Crockett. We'll catch you next time on the Just Start the Conversation podcast.